Welcome if you're just joining us. This is Healthcare for All Washington's second Wednesday speaker series. We're about to bring in some providers from Norway to share their story. So thank you for joining us. I'm Ronnie Shure. I'm a retired pharmacist and I volunteer as your president. The volunteer is the key word there, but you too can volunteer and help out with Healthcare for All. We're posting a link in the chat box. If you click on that link, it'll take you to our website. There's a page to volunteer, a page to sign up, add your emails to get email messages, add your address to get written copies, and also a chance to donate. Your donations, if you are able, really make a big difference in helping move us closer to universal health care here in Washington State. We've set a goal tonight to raise $500, and even small amounts do make a difference. So go into our website, look in the chat. You can make a donation at any time during the presentation. And in the chat, we also is our opportunity to add questions for our moderators to help answer at the end of the presentations. So while you're in the chat, add a question. Also look for the donate button or go to our website. You'll also see that at the bottom of the screen, in the middle of your screen, is a closed caption or CC button. I have enabled closed captioning so that you can understand some of the things that we're saying so that you can follow along. Sometimes sound varies from one of us to another of us, so please feel free to click on that closed captioning button. Let's start with a land acknowledgement. I'm participating in this Zoom meeting tonight from the lands of the Coast Salish peoples. Please take a minute to acknowledge the peoples from the land where you're joining us from today. We acknowledge all of the ancestral homelands and traditional territories of indigenous peoples who have been here since time immemorial. Our efforts to achieve healthcare for all include universal complete coverage for the Coast Salish peoples of this land, the land which touches the shared waters of all tribes and bands within the Duwamish, Muckleshoot, Puyallup, Suquamish, and Tulalip nations. The moderators for tonight's program are a former board member, Ruth Knagenhjelm, who retired from her physical therapy practice in the Seattle area and returned to Norway, and a current board member, Sherry Weinberg, who has retired but moved to an island in the middle of Lake Washington called the Island of Mercer. So let me welcome our retired Norwegian moderator, Ruth, and our retired pediatrician, Sherry. And let's get started with some introductions of tonight's speakers. Sherry?
Okay. Our first speaker it will be Sarah Kaldestad. She is a primary care doctor in Norway near Oslo. She is originally from the Bothell area, where her father is a family practitioner. She went to the University of Washington, but she is also a graduate of the University of Oslo. Hi, Sarah. So as a retired primary care pediatrician to a primary care physician in Norway, tell me about your practice there and what it's like.
Yeah, thank you. I work in a suburb outside of Oslo in a primary care facility where there are like 6 doctors and then myself, and I'm kind of a floater where I help out the other doctors.
Talk a little bit about, because I know you have some experience with your dad being a doctor here in US and you in Norway, and as far as what the administrative burden is in Norway versus in US, if you can kind of explore that a little bit.
Yeah, there are huge differences. So from what my dad tells me, he's in family practice in the Seattle area, that there are just like so many kind of meaningless boxes that have to be ticked all the time for patients. Like even if you've been seeing someone their whole life, you still have to ask them every single time, you know, are you smoking? Do you own a gun? Blah, 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 all these things. And then there's the insurance paperwork, which I know many doctors in the US complain about a lot with, you know, having to call insurance companies all the time to get patients' treatments approved. That's not something I have to do in Norway very often. Most medicines that I would prescribe on a day-to-day basis are already like pre-approved for the normal diagnosis you would use them for. So it's just a couple clicks and then you've sent the prescription. You don't need to worry about the patient not being able to purchase it. Only in special cases do you need to kind of like apply to the authorities for a medication to be approved. So pretty big differences in the way just the day-to-day stuff is run.
And you said that you have, it differs from clinic to clinic if the staff you have is paid for by the municipality or by yourself.
Yeah, typically most doctors that are in primary care here are self-employed, and they're also responsible for paying for their own staff. Some of the money you get from the government is supposed to cover that, but in areas that have trouble getting enough doctors, sometimes the municipalities will offer something more lucrative, like maybe they'll give the doctor free rent on the office building, or maybe they will pay for the staff. So there's definitely ways of doing that also.
Yeah. And as far as reimbursement goes, I don't think you mentioned it here quite yet. As far as the 3 different sources, you just clarify that again, the 3 different ways you get paid.
Yeah, so for a typical doctor here who is a fastlege, a primary care doctor, you have maybe 1,000 patients on your list, or 800 or something. Anywhere between 600 to 1,200 is pretty normal. You get a certain amount of money each year from the government per patient. So that money is called like your basic supplement or something, basistilskuddet in Norwegian. That money is sort of intended to cover the cost of like your building and paying your staff. Then for every time a patient comes to see you, they will pay a small amount, typically, you know, 20 to 40 US dollars would be the typical for what they would end up paying. And then if you've done anything sort of in excess of that amount, you send that bill also to the government, and then you get reimbursed from them. So it ends up being 3 different sources. And then once the patients have met their ceiling for what they should pay in the course of the year, I don't remember the exact amount, but it is not very high. And the ceiling includes, it's like all medical treatment, physical therapy, you know, x-rays, all of these things go in the same pot for what you would call your deductible in American insurance. It's maybe roughly $400, something like that. And then beyond that amount, they wouldn't pay anything when they come to see you, and I would bill the government for the full amount.
Yeah, I mean, just as a patient now in Norway, I kind of gotten to know it's about, you know, with the current dollar exchange rate, about $300 a year.
Yes.
For these co-pays. And, So there's those co-pays, and then you get like a fee for service from the government, and then you get that business operation stipend. So I was just want to clarify those 3 different ways.
Yes.
Where you get how you get your money.
Yeah.
Or reimbursements. Yeah.
Everybody wants their money. Yeah.
Which differs from, here in the States, if you are a so-called self-employed, you don't have that guaranteed grant for, the business operation.
Right.
You just have the fee for service and copay.
Yeah.
But I would say, that ceiling is really something that helps because, as far as, I would say that Norway doesn't really have what you call deductibles in the United States. Norway has the co-pays, and which has a yearly cap. That's about it. Yeah. So you don't have to worry about, like here in the States, as far as, okay, the deductible is either, $3,000 or $4,000 or $10,000 a year, or it all depends on your insurance, So I think that as a patient in Norway, I would say, oh, this is such a good relief. I don't have to worry about what this is every year. Or if I, have to change insurance, or my employer changes insurance, and then you have to just really stay on top of all these little details as far as, copays and deductibles and premiums.
Yeah. The costs here are on a totally different scale. Even if you chose to go fully private, as some people do, because they don't like their primary care doctor they're assigned to or something, so they'll go to some private clinic. But even doing that and paying the full cash amount, it is still way less than what you would pay in the US for the same service typically, like, something like an MRI, or, seeing a gynecologist or something like that. It's just on a totally different scale than what things have ballooned to in the United States.
Well, that was very, very interesting. I've already written down one question to ask later, but we'll come up with that later. So Ruth, you want to move on to introduce our next speaker?
Yeah, I'm going to introduce then Eileen Nøstund. She is a dentist, and she has practiced dentistry in the county of Hordaland in Norway for about 40 years, and in the public dental health service there. And this county surrounds the city of Bergen. In addition, she has served as the administrative manager for the Central Bergen Dental District, with responsibility for 12 clinics and 70 personnel. And she has also worked a little bit with the Norwegian State Department for Health and Social Welfare in Oslo. So here she's come up and describe a service that is not fully covered by the Norwegian healthcare system. Hello, I want to welcome you, Eileen, practicing dentist for a long time in Bergen in Norway. And I would hope that you can give and describe the dental system in Norway and how it affects different groups in Norway. So I give you the word to you.
Thank you. Well, the Norwegian dental system is divided into 2, a private system and a public system. About 75% of the dentists in Norway work in the private system, and their patients are adults above 22, and those are people who can afford to pay themselves out of pocket, because there is no support system, no insurance, no co-payment, no workplace that take care of the dental problems of their workers. So the other part is the public system takes care of primarily children from age 3 to 18. They get all treatment for free except orthodontic treatment, which is done by private orthodontists. But still, paid in part by the state. The next group is the mentally disabled. They have free dental care for their whole life. The third group is the elderly and disabled people in nursing homes and in home care. They get 100% free care. And then you have the fourth group is 19 and 20-year-olds. They pay only 25%. And for a couple of years now, we also had the 21 and 22-year-olds who pay 50%. And now there is also a suggestion to include the 23 to 26-year-olds, but that hasn't happened yet. And then the fifth group is a group that the politicians in each county decide on a political level who will be included. And not all counties include anybody in this group, but in the county where I have worked, and that Bergen belonged to, is they have included drug users who are under substitution treatment. They get free dental care. But other drug users who are not under treatment, they have to pay themselves, and obviously they don't go to the dentist.
Thank you so much. Anything else that you want to add as far as just from your general experience and in dental practice for so many years in Norway?
It is a fact that dental disease is a consequence of socioeconomic status. So nowhere else in the body will your socioeconomic status show so fast. Like if there is a change in your status, like kids in a family that has been functioning normally and have had good dental health, if that suddenly changes, the dentists see the changes and have to ask, what happened here? And then you can be sure that something happened in that family, like a divorce, like some disease, maybe depression, things that result in worse care for the teeth. And so that is what we see in our practice, is that there is a huge difference between the dental status of children from different kinds of socioeconomic levels. And the worst problem today is the dental health of the immigrant children, because they are usually very poor, and there is also a different culture and a different educational level. Dental health of a kid is a consequence of the educational level of the mother. Of course, that shows when we see bad conditions, it is usually a result of lack of education of the mother.
Well, thank you so much, Eileen, for that description to us, and I think that will help us understand that every healthcare system struggles with some deficiencies, and no system is perfect, but it seems to me that Norway are still going towards including more and more groups in the public system and trying to improve it, at least.
Of course, we are trying to improve it, but there are different opinions on how we do that. And many of us would want a system for the dental health that we have for the general medical health. You know, in Norway, hospitals are free, and medical appointments are, you have a slight co-payment, but not much. So compared to the US, it's almost free. We think that the dental system would benefit from being included in the medical system. But the system is very old. It's more than 100 years old, and the few changes that has been, like public system for these groups that have free dental treatment, that happened in 1949, and it was changed in 1984 to include more groups and to move the school clinics out of the schools and have clinics for everybody, but still the adults had to pay. So it is a patchwork of different payment system for the different vulnerable groups, but it will probably be very difficult to change the system now after so many years. So I believe that in the future we will maybe include more groups, more age groups probably, but the basic system will be a divided one with a big private system and a much smaller public system.
All
Well-
right, we thank you again to Eileen. And then yes, we will have an introduction of
Yes.
Stein Emil. Thank you,
Yes.
Sherry.
Stein Emil Vollset, who you've seen a picture already because he is Eileen's husband. He is a professor of health metrics at the University of Washington in a department by that name that really took form once it recruited Dr. Chris Murray from the World Health Organization. He was behind the study that led to a World Health Organization report on healthcare systems around the world in 2000. I will get us started with asking a question of Stein Emil about a comparison of life expectancy between Norway or among Norway, Washington State, and the United States entire country. So take it away, Stein Emil.
Okay, thank you. Yeah, I will share with you today some data on the health status of the US, Washington State, and Norway. And all the data I'm showing you, they are from the Institute of Health Metrics and Evaluation here at the University of Washington in Seattle, where we do the global burden of disease study and collect the health data for 204 countries, and 22 of these countries, including the US and Norway, we also do at the US state and Norway county level. And we study a total of 370 diseases and injuries by age and sex, and we study both mortality and morbidity or deaths and non-fatal health burden. And I will show you today measures of life expectancy and what we call healthy life expectancy, and also a health system index that we produce. This is to start the comparison between Norway, Washington, and the US as a whole. On the left-hand side here, we see life expectancy from 1990 to 2019. That was published with the global burden of disease 2019 cycle. And actually, quite interestingly, we can here see that in 1990, the life expectancy was the same in Norway and Washington state, and the US was around 1 year less than the two. But after that, the comparative picture has changed quite importantly. In Norway, we had quite a steep increase in life expectancy, reaching 83 years for men and women combined, whereas we now have a gap of more than 2 years down to Washington state, and a gap of almost of around 4 years between Norway and the US in 1990. And you also see that the US as a whole has had actually no progress, no growth in life expectancy for the past decade. And if we rank Norway and the US among the 204 countries, we now have Norway as number 10 and the US as number 43. And if we had placed Washington in, it would be number 34.
Worse, US since COVID.
The 4-year difference in life expectancy between Norway and the US can be explained by 4 disease groups. Cardiovascular is the biggest, 1.4 years can be explained by that. Then comes injuries, and followed by diabetes and chronic kidney disease, and then drug deaths or opioid epidemic deaths of similar magnitude. On the right-hand side here, we see IHME's health system index, health access and quality index. And this index is based on an analysis of causes of death, around 30 causes of death that should be rare or not occur in a country with an effective health care system. And also here we see that in 1990, the US and as a whole and Norway were at the same level measured by this health system index, whereas Washington state was actually above. And again, the picture has changed in a similar fashion, that Norway has had quite as much steeper increase in this health system index. Washington has stayed, and the US has increased about the same. Both have shown progress, but now Norway is on the top, Washington in the middle, and the US lower. And the ranks, if we across the 204 countries, is 9 for Norway, 27 for Washington, and 33 for the US. This is a list of the top 50 countries ranked by life expectancy, and I'd like to show this because you can see Norway is, as I said, at almost 83 years, is number 10. See, Washington would be number 34 if we treated it as a country between Puerto Rico and Taiwan, and US a bit further down on the list. On this slide, life expectancy on the left is the same, but on the right-hand side, I show what we call healthy life expectancies, and we see that the healthy life expectancy for Norway in 2019 was close to 71 years, which was about 12 years below the life expectancy. So in Norway, we can expect that the individual live 71 years in full health. And what's important to note here is that it's actually the number of years lived in full health. The differences between Norway and Washington and US, they are larger than for life expectancy itself. So this is explained by what we call the non-fatal disease burden, which is the most important large group of non-fatal health burden or suffering of a condition or diseases that you don't die from, is actually musculoskeletal disorders. So this is low back pain, neck pain that could be linked to the obesity epidemic, maybe less physical exercise, and other factors. My final slide is actually going back to the difference in life expectancy between Norway and the United States. And the question I try to answer here is, what diseases and injuries explain the difference in life expectancy between Norway and the US? You see on this red line, vertical line on the left, that's the US life expectancy in 2019, 79 years. And we have Norway over here at 83 years, so 4-year difference. We see here cardiovascular disease is the disease group that explains most of this difference, around 1.4 years. But other major contributors to that difference is drug deaths or opioid deaths, and diabetes and kidney disease in orange, but also the combined set of injuries we study in the GBD accounts for 0.7 years, and that's mainly due to road traffic accidents shown in light blue, and to suicide and homicides that are shown in violet to the right. There is much less difference between Norway and the US when it comes to unintentional injuries like falls and other types of accidents. We can also see here that there are a few causes where actually the US has an advantage over Norway, and cancer, shown here in black, is slightly, the situation is slightly better in the US than in Norway. And also for the blue here is pneumonia.
Well, thank you. I think this is interesting information for us to think about in what we could do if we had a national health system with adequate coverage for everybody, and if we paid attention to some healthy lifestyle things that might affect the big things there, the cardiovascular disease, drugs and drug usage, and diabetes. But thank you very much. Well, those are our 3 Norwegian experts, and I've also been copying out a sketch of a lot of the questions that have been in the chat. But we have a couple of people who are going to ask us the questions from the chat and see how we can deal with them.
So thank you, Sherry and Ruth, for helping to coordinate that, and especially thank you to everyone for throwing some questions into the chat. We will try to put those together. Ron, if you can put me on the screen, I'll promise to smile. And also, let's bring in Peter Lucas. So before we move on, Peter Lucas is another member of our board of directors. So Peter, we have been entering the link for our website into the chat. So as people enter their questions, and please continue to enter some questions in there. This went actually faster than I thought it would. So we will have some time for questions. But first, Peter, why don't you tell us about donating, about accessing the website?
Okay, well, thanks. Well, I first want to say we're really kind of overwhelmed by the attendance tonight. This is a very well attended meeting, and we're especially pleased to see some new faces. So welcome to you all. And I want to say a few words about our organization. For those of you who don't know about our organization, but also those of you who do, we've chalked up many legislative victories in Olympia over the last few years, including helping to establish and appoint members to the Universal Healthcare Commission. And this is a group that could craft a publicly financed universal system based on our bill, the Washington Health Security Trust. And maybe we can bring something resembling the Norwegian system we learned about tonight to our state. But in order to maintain our momentum, it is vitally important that we grow our membership, educate the public, and mobilize our supporters to spread the word to their family, friends, and most importantly, their legislators, especially now that they're in session this week. And we can achieve these goals through social media, monthly webinars such as tonight's excellent presentation, meetings with civic groups, and by hosting other events. Lately, we've been trying to get out more from behind our laptops and smartphones and meeting with people in person. That's still a work in progress given the various pandemics going around. But we're also pleased that we have a new and experienced and dynamic lobbyist who's doing great things in Olympia. We have a communication specialist and other fixed costs. Now, what we do is not free. These activities and obligations all require funds, which is why we are asking you to donate tonight. So the goal we've set for tonight is $500. So please go to the links in the chat or our website, which is new and improved. It's really pretty spectacular, and click on the donate button. You can make a one-time donation, but what's really valuable are monthly recurring donations. And that's an option when you go to the donate section of our website. So please donate so we can spread the word and bring about universal, publicly financed healthcare in Washington. That is the moral imperative. Thank you for listening.
And thank you for everyone who has donated. There are even some new members or first timers who joined us tonight that have made donations. There's even been a recurring donation. And there's also an opportunity to volunteer to help us in planning actions and organizing our interactions with legislators. So thank you all so much for being a part of that. Want to get back and keep entering questions into our chat. There are a number of questions that we may have to answer in another format to get back to Eileen and Stein Emil and Sarah to get some exact questions. But I think Ruth and Sherry, you can answer some of the questions because we've already had those answers. So everybody's unmuted, which is good. So one of the questions, in fact, first, let's mention that what Glenn Anderson added to the chat, which was a great reference for a book called Viking Economics. The author is George Lackey, and it talks about the approach to healthcare and to all social services in Norway and other Scandinavian countries, which is, I think, one of the progressive facts about healthcare there. So let's look at a question, Sherry or Ruth, about do doctors need malpractice insurance? That was an issue you talked with Sarah about, right, Sherry?
Yes. The answer is they do, but not very much. It's very cheap, on the order of $100 or so a year. And there are two reasons for it. First of all, Norwegian has a no-fault system, well, it isn't quite no fault, but what they do is when there's an incident and it's reported something of a bad result, then a committee takes a look at it, interviews people, investigates, and decides what went wrong and why. And is it a system problem that we ought to fix? or was it a mistake made by a doctor or by a hospital or whatever? And the important thing to understand is that malpractice insurance in the United States has to cover the ongoing continued health care as a result of the accident, whereas in Norway, the ongoing health care as a result of the accident is covered. So they don't have to sue for that. So it's mostly, is there a way to improve things? And if the doctor screwed up in some way, then they work first to educate the doctor or to work on what way the system should have caught the doctor's misbehavior before it happened. So it's more looking at it that way of how do we fix it rather than who should pay how much to whom. And the net result is much lower cost of malpractice insurance.
And the other issue on top of all that is, or underneath all that, is the fact that the healthcare system, it does have some regulation. There is a role for government to play. And a big part of healthcare in Norway is these improvements, coordinated programs to educate us, to educate providers, and also to educate patients on using the system appropriately. And that's how we cut down on errors, is by having someone lead that particular process. So there were several questions. Ruth, do you want to add something there?
I can quickly add one regarding the reimbursement rates, fee for service, asking if it's the same for all providers or set by the government. Yeah, the reimbursement rates for the doctors that are, or the physical therapist or other providers that are in the public system that Sarah talked about, that has a contract with the government, the rates are negotiated with the providers. And so they are the same. They differ for different services, but what the providers get is the same.
Right. A related question is, are co-pays the same for all patients, or is there a sliding scale based on income?
They are the same for all patients, but they have some exceptions. And one of them is low income, where you can get an exception. And another one is if you are have chronic conditions, then you can also get the free pass on the co-pays. And then again, as she mentioned, the ceiling per year is $300 to $400. So you're not talking about a lot of money.
And 76% of healthcare costs are paid by taxes, and it is a progressive tax system. So there is national insurance plans that employers provide about 10% of healthcare costs. And there are certainly out-of-pocket expenses. But just like Ruth was stating, there are exceptions, or there are qualifications made to pay the out-of-pocket expenses for certain groups, for certain ages, or for certain conditions. So there are several programs that are developed, and it's divided not just nationally, but through counties and through municipalities. And I think despite in addition to those particular distribution of payments, the hospital system, which is the biggest cost in healthcare, is paid for, is employed by, and providers are employed by either the national government or the municipalities or counties. So that cost is much more uniform and is addressed by that role of government.
Yeah,
Peter, you have a question you've seen in there?
I would like to just add right there, Ronnie, to all hospitals are free. There's no co-pays at the hospital for hospital services at all. Also, yeah, I guess that was the main thing. And as far as people pay about 10% payroll tax, but the healthcare system pays for so much more than just healthcare. You know, you have all the social services, you have got unemployment insurance, you've got parental leave, everything is included in that one payroll tax. So it just covers so much more than, you know, here in the United States, it's all split up in different kinds of insurances. And in Norway, they just put it in in one pot.
I saw a question, what about the homeless?
I would think that the homeless, if they can get themselves to a doctor and, you know, make the appointment and so forth, they are, as long as they are a resident of Norway, you know, they get the care that they are entitled to. There's no difference there.
I bet they have fewer homeless in Norway compared to the US.
Yes, they do. And I think there in Norway, there's a law that they are supposed to provide housing to everybody, you know, so they are not out sleeping on the streets. But, you know, with drug addicts and, you know, alcoholics and whatever, you can't always reach everybody.
Right. So you end up with a much smaller number, but you have a larger social services structure to help, because most of what the homeless need is not medical care, it's social services.
Exactly. So because of the whole system is so cohesive, like the socioeconomic is kind of bundled together. So it's not, you know, healthcare is not separate from the social services. So
I thought there was an interesting question about the Sami people, and are they included? And first of all, the Sami as a group actually moved from summers in Norway to winters in Finland. So are they covered by each country's system when they're there? What, do you know anything about that, Ruth?
The only thing I know is that, you know, you have to establish residency. Either you choose it in Finland or you choose it in Norway, and you have to and you live in more than 6 months in the country where you have your established residency. And if you have that established residency, then you are covered. Yeah, and then you also, of course, have to pay your taxes according to what the laws are.
Right.
There are a couple of questions about the quality of care, and I think that's an issue that Stein Emil tried to emphasize by providing statistics, but he did share comments with us that were not on the recording. It's and I was wondering, Sherry and Ruth, if you might share some of his comments about the fact that yes, the healthcare system does make a difference in amenable causes of disease, of injuries or cardiovascular disease and diabetes. That seems to extend the life expectancy. And certainly the key outcome is that it's getting better in Norway, whereas in the United States, it's not. It's getting worse. There certainly has been a pandemic in Norway as well as here, and that's impacted that increase in lifestyle. But for over a decade, it's been moving forward, and that's outcome is a sign that people are getting better results from their healthcare system, but also from the entire social system in Norway that supports, that moves people into housing, that maintains income. So preventing people from being having nutritional deficiencies, and showing, I think Eileen, our dentist, talked about how socioeconomic social determinants of health really show up in a patient's mouth and dental care. And it's certainly an important part of the future of their health, or maintaining their health, or moving back. But I think there are key underlying factors that make that such a difference.
So I see a question here. Do patients or employers pay insurance premiums to insurance companies, or is healthcare covered through taxes to local or federal government? And employers pay, it's kind of like a little bit like Social Security here in the United States. The employers pay a part, it can be 0 to 14%, depending on where that employer is located in Norway, because they want to have incentives for some industries to move to some rural areas and, far up north. And then the employees pay about 10%. And but if you're retired, you pay about 5%. So they have, and then a little bit of what you pay in income taxes also is allocated by the government, as grants to the counties and municipalities, for the care that they give there. But as a patient yourself, you are looking at the 10% or the 5% if you're retired, and then the co-pays that you pay, and that's about it. You don't really have to worry about anything else.
And no insurance company intermediaries.
No.
Right.
And this question about changing the primary doctor, if they don't like the doctor they are assigned to, yeah, they instituted a law about a few years ago that says that you can change your doctor after 6 months if you're not, content with the one that you got assigned. And the only issue is that if you're living somewhat in a rural area where you might not have a lot of primary care doctors, the choice might be a little limited, or you might have to wait a little bit longer to get that particular doctor that you want. So, but that's, not something that's, you just cannot have an abundance of, contract with doctors in small towns and whatever, or in rural areas. I mean, that would be not cost effective. So it's, you can't just get everything. But
been a couple of questions about wait times. Are there wait times to get appointments with physicians? Or is it, I mean, all systems all over the globe have been struggling some with the pandemic, but trying to put that effect aside, is it difficult to get an appointment with your primary care doctor?
No, the primary care doctor is not that difficult to get. The difficulty, I would say, is with the specialists. And the specialists are working mostly at the regional hospitals and have contracts with the government there, or are salaried at the hospitals. And they can have some wait time. But as Sarah said, if you want to choose a private practitioner that's not contracted with the government and pay maybe the $200-300 to see that one for a second opinion or so forth, that is a possibility. But overall,
Is that common?
Well, I think we can look at the reports on access to care when Norway is compared to other countries in the world. The Commonwealth Fund rates them as having the #1 access to care, or a system that responds to people in among all the developed countries in the world. And there are more concrete comparisons within Europe, comparing Norway against other countries in Europe, showing some clear advantages there. And certainly we should keep in mind that if you don't have healthcare coverage, like many people don't have in the United States, then it's a really long wait time. It's ending up in the emergency room with often complications from that infection or from that cause. So there are some other questions that we have not answered that we will put together and provide some answers. So there's still time to check out our website, make a donation if you are able, volunteer if you are interested. We do have committees that are working on several different issues, so please go to our website and do that. I want to thank everyone who participated in developing this program. To Ruth, so glad you came and visited us and inspired us to have this program. Sherry, for your time and commitment and your history with healthcare reform. To Sarah Kaldestad, the primary care physician in Norway who was born in Bothell, and Marcia, thank you for connecting us with Sarah. She grew up next door to you and made this a much more meaningful process for all of us. And thanks to Eileen Nøstund and Stein Emil Vollset, Stein Emil has been teaching at the University of Washington and was a connection through the leader of Daughters of Norway through the Scandinavian community here. So thanks to Elaine Greggs for helping make a connection with those two speakers. And I also want to thank the people behind the scenes, Ron Lovell, Rich Legoo, D.W. Clark, who have been helping make a difference. And Peter, thanks for your help tonight. And Marcia for helping us manage that chat and getting the website in there. And everyone who has had a part in this second Wednesday speaker series. And especially to each of you for joining us. It's inspiring for us to keep doing this work when so many people show up. So thank you, thank each of you. Please consider joining us for our next next second Wednesday speaker series in February. We will be doing a wrap up of some of the legislative actions that are going on. So it'll be an alert rather than a wrap up. It will not be a wrap up because things are just starting down in Olympia now. So please join us again in February and have a safe remainder for January. Thank you all very, very much